if a physical therapist wants to take necessary steps to become a primary care physical therapist, what are necessary steps that they need to inquire in order to become one?
Yeah, that's a really good question. And I think that it really depends on how the primary care PT is going to be utilized.
Okay.
And the primary care PT, the goal of having a PT in primary care is going to be different depending on what the needs of the system are. So let's say you have two different primary care clinics.
Hmm.
One of the primary care clinics is in a rural location, and maybe this clinic only has access to like a nurse practitioner and a physical therapist, and that's it.
Hmm.
And then you have a second location that has that's in more of like a suburban health system, and they have a lot of providers, but they also have a really big problem with a backlog of musculoskeletal injuries.
Hmm.
We'll start with that one.
Okay.
With that one, the PT might be utilized in the primary care setting to exclusively assist with the backlog of musculoskeletal problems that are being managed there.
Hmm.
And that primary care PT should ideally be, really well trained and skilled in orthopedic assessment, acute musculoskeletal injury assessment and management, things like diagnostic imaging, evaluating and understanding when it's important to incorporate blood labs. So in the case of, you have somebody with a musculoskeletal complaint that you actually think is inflammatory in nature, and they might need some, a rheumatologic workup, just knowing when that's appropriate and when
Hmm.
to direct care in that regard. So on that team, the primary care PT would be serving as like this musculoskeletal consultant expert that's a part of the primary team.
Okay.
On the other side of the equation, you have somebody who's in a rural area,
Hmm.
and they could literally see anything that comes through the door. So this person should know and be familiar with what the population health makeup is of the region that they serve and of the people that they serve. So rural could mean different things in different locations.
Hmm.
In northern Wisconsin, that could mean, people that primarily survive from, maybe they're loggers or fishermen or, things like that. In another part of the country, that could mean, almost everybody that you serve is a farmer.
Hmm.
And what that indicates as far as their health makeup and their health outcomes and their interest in even accessing healthcare in the first place. So
Right.
that the person in the rural setting will need to know what is the makeup of the geographical population that they
Hmm.
serve. And they might need to know a little bit about everything. So the primary care PT serves as the neuro PT,
Hmm.
the pelvic health PT, the ortho PT, the
Hmm.
vestibular PT. So that person would be very well suited to understand the basics and the fundamentals of every practice area that there is. So it's like taking our entry level competencies
Hmm.
and bringing them up to speed so that you can serve anybody that comes through the door, at least at a basic level. We're not asking for primary care PTs to be, the experts of every last little thing, but
Hmm.
they should be pretty darn familiar with most of the conditions that could come through the door at any given time. And that's not limited to orthopedic and musculoskeletal. It also includes, how to work with patients that have COPD and they're on a dyspnea spiral and they're
Hmm.
having trouble with their functional capacity because of their shortness of breath and things like that. That's all within our scope to assist with.
That's true. It seems like PTs have very wide variety of handling cases. Regarding that, for instance, Texas, direct access is only valid for 10 days without a referral. Let's say if you're a primary physical therapist in that state where you are limited to how many days a PT can see a patient without a doctor's order or referral, what role do you think they play in an area where there's a lot of musculoskeletal injuries happen?
Yeah, I have two suggestions for that. The first one is get involved in your state advocacy efforts to
Hmm.
squash that, because It's unacceptable at this point in time,
Hmm.
since our standard is a doctorate of physical therapy across the country.
Uh-huh.
Um, it's unacceptable that we don't have unrestricted direct access, especially because we know how and when to refer. And
Hmm.
10 days is absolutely ridiculous. Um, that's a ridiculous time frame to be able to work with a patient to see how they're going to respond to care. Because
That's
in
true.
physical therapy and rehab, we know that healing and adaptive changes to exercise and to other, conservative measures take time,
Hmm.
take 6 to 8 weeks sometimes to really see those changes. So I think that's outrageous. So my first suggestion is get involved in your state advocacy efforts to squash that and change it.
Hmm.
My second suggestion is make friends with a physician or a nurse practitioner or a PA or whatever, whoever needs to, sign off on your quote unquote plan of care,
You're right.
um, in order to make stuff happen. Because
Okay.
I think that, like, for the most part, the physicians and other medical providers that I've worked with have been highly supportive
Hmm.
of PT and the services that we can provide.
Hmm.
And they often feel that the things that are required of us that they have to like sign off on
Uh-huh.
are really antiquated and ridiculous. And it's just an added administrative burden for them, anyways. And guess what? Most of the time, when we fax our notes over, the person who's signing it is not the physician, it's their MA.
Okay.
So, like, it's just kind of silly, those two things. But I think that if you work in one of those states where direct
Hmm.
access has a high degree of limitation, make friends with a physician who is supportive of you so
Hmm.
that you can, send these plans of care to them in order to like get whatever you need so that you can continue to work with patients without interruption.
Thank you. Yes, so I did work with a lot of physicians, and seems like they do agree with everything that we say, and also alter their plan of care depending on what we have to say for the
Yeah.
patient. So I, because we're the most people who would spend most of the time with the patients, not them.
Yes, exactly. And the few instances that I'm aware of where a physician or a medical provider has been reluctant to proceed with a suggestion from a physical therapist, they end up sort of crashing and burning at not following through with those requests. In fact, we
Hmm.
just had a showcase not too long ago where one of the presenters shared a case of a patient who was presenting with shoulder pain,
Hmm.
but the physical therapist thought that it was cardiac in nature,
Mm.
referred him back to the primary care physician saying, this doesn't seem musculoskeletal. This seems cardiac. It seems like
Hmm.
he needs a workup. And the physician sort of ignored it and said, no, it's musculoskeletal. And,
Yeah.
it turned out that he had a 90% occlusion in his left anterior descending coronary artery.
Uh-huh. That's
So,
crazy.
I mean, so then that ends up really falling on them if they don't do the appropriate investigations upon our suggestions.
Hmm. Thank you so much. And I appreciate you being a very strong advocate for primary care. I would do that on my end as well so that PTs in every state can get their, I guess, opportunities. So,
Yeah.
as an advocate for primary care, how do you perceive the progress made in the United States in recognizing physical therapists as primary care providers? And what areas are still in need in attention or advocacy efforts to enhance this specialty?
Well, I think that we have a lot of work to do. But the work that we have to do has more to do with changing the culture of our own internal profession than it does with anything else.
Mm.
The one of the biggest barriers that I've come across is physical therapists just not wanting to go down this road or not being interested in moving into this space.
Hmm.
And I don't understand what the reluctance is or what the hesitation is. I think
Hmm.
that it's just one of those things that where culture just evolves over time,
Hmm.
especially since our profession has gone from a bachelor's to a doctorate in a
Hmm.
period of about 20 years.
Hmm.
So that's not that long. And, we still have bachelor's level PTs working in our profession. So I do think that there's a really big evolution that still needs to take place. It's getting better, but it still needs to be worked on. Um, And does every PT need to be a primary care PT? No, definitely not, because we still need people to function in traditional rehab roles,
Okay.
you know, acute care, inpatient rehab.
Mm-hmm.
We still need, you know, a good amount of people to do post-op type physical therapy.
Mm-hmm.
But our ability to move into this first contact space is not just about us and progressing our profession. It's about helping patients receive better quality
Mm-hmm.
and faster access to appropriate services. This is why behavioral health moved into primary care space, so they could meet a need
Mm-hmm.
without having these long delays between the time they first seek care and the time that they actually seek the right care. So we want to match the first point of contact
Mm-hmm.
and the right care with the same team. And then the second point just about progress has to do with, you know, well, if we identify the areas of cultural change that need to happen,
Mm-hmm.
there's a whole lot of other, you know, legislative, regulatory,
Mm-hmm.
institutional
Mm-hmm.
changes that need to take place. And I'll give you one example. There is a Medicare policy on federally qualified health centers, which are reserved for individuals who, you know, qualify for Medicare, Medicaid, and in these FQHCs, physical therapy services, PTOT, and speech services can only be billed for by a physician, a nurse practitioner, and a PA,
No
which
way.
is yeah, and this is an actual policy. So these FQHCs, they can hire and employ a physical
Mm-hmm.
therapist, but a physical therapist working in an FQHC cannot bill out for physical therapy services and get reimbursed for it. That's crazy. And
Mm-hmm.
that's in 2024. So if we're here, like that's just something that seems like it was written probably 60 years ago and just has
Sure.
never changed.
Uh-huh.
So these are the things that we need to really be proactive on, like advocating for the changes in the language for. So there's a lot of work to still do, but
Mm-hmm.
I can assure you that in the primary care special interest group, my team, the board members that I'm surrounded by, and our members are very much moving into these spaces and trying to tackle these big issues so that we can eliminate the barriers and proceed.
That sounds very exciting, and thank you. Based on your experience, what advice would you offer to new graduates or early career physical therapists aspiring to specialize in primary care? I know that in the first part of our interview, you explained that you are running a Redefined Health Education
Mhm.
website. Could you please tell us on that as well in order for us to enhance our skills or education in terms of becoming a primary care PT?
Yeah, so my organization, Redefine Health Education, which our website is redefinehealthed.com.
Mm-hmm.
We have a variety of courses that really emphasize what the primary care PT needs to know before they start functioning as a primary care PT. And we have a lot more stuff coming out too. So we have a musculoskeletal imaging certification, which I think is absolutely essential. We also have our Foundations for Primary Care PT course, which covers the basics of all of those body systems and just how to function as a healthcare professional who really manages care as opposed to just provides treatment for a short window of time.
Mm-hmm.
There's a distinct difference there. We also have some crash courses in specific topics like oncology. We've got one coming up in chest imaging. We've got another one coming up in cardiovascular conditions in athletes. So we're going to have these crash courses, and the purpose of them is not to take a huge deep dive and get certified in all of these different nuanced areas, but it's to provide a general overview of what you need to know about working with different common populations that you might see in a primary care setting. So we have all of these course options available. I also offer a mentorship program where that can really be customized to whatever your individual needs are.
Mm-hmm.
And then I would also like to just close by saying the APTA primary care SIG is we've been in the process of writing up a clinical specialty, a whole new specialty area in
Right.
primary care PT,
Mm-hmm.
which currently right now it is sitting with ABPTS, which is
Wow.
kind of the authority to
Yes.
that will ultimately make this move forward. And we hope to hear back really soon. But if that comes to fruition, hopefully, fingers crossed, in August of 2025, then we will have a whole new clinical specialty. And I'm sure there's going to be lots of courses and resources to look at once that comes to fruition.
I'm really excited for that and hope that will come soon, maybe next year, right?
Me too.
Thank you, Dr. O'Brien, for sharing your insights with us today. Before we wrap up, would you be willing to share your contact information for individuals seeking further clarification or information?
Yes, absolutely. So my email address is info@redefinehealthed.com. I already shared the website. And then on social media, you can find me on pretty much all of the platforms at Redefine Health Ed. So that's REDEFINEHEALTHED. A lot of people put a D on the end of redefine, so I like to spell it out. The
Okay,
only one that's different is on X or Twitter. It's redefine con ed, so CONED.
gotcha. Thank you once again, Dr. O'Brien. Have a nice day, and we look forward to hearing back from you and all the changes you made in the realm of physical therapy.
Thanks for having me.